very interested in the Exposomics framework and advancing Alzheimer's disease and related dementia research. And so I know a lot of folks may not be familiar with NIA, and so the NIA mission is really to support and conduct genetic, biological, and clinical, behavioral, social, and economic research on aging across the entire life course. And it really is trying to foster and develop research and clinician scientists in aging, and really provide research resources and disseminate this information to not only advance public health, but also to impact healthcare practice and then in the scientific community as well. And so I know a lot of folks may not be familiar with Alzheimer's disease. It is a brain disorder that progressively impacts memory and thinking skills, and eventually the ability to carry out simple tasks in life. And so most people with Alzheimer's symptoms first appear later on in life, but it's really the most common dementia diagnosis in older adults. And some of the hallmarks of Alzheimer's is buildup of amyloid plaques and tau tangles. The Alzheimer's disease burden is anticipated is about 6.7 million individuals within the United States currently have an Alzheimer's diagnosis, but it's expected to grow by 2050, to double by 2050. And it also impacts around the world. So the Alzheimer's disease in East Asia here, in persons over 65 years of age, in Europe and US is about 3 to 7%. But in Japan it's about 2%, Taiwan about 4%, and People's Republic of China around 5%. So it really represents a significant financial burden with an estimated 43% of the patients require a very high level of care. And so worldwide, the total cost is approximately $604 billion US dollars in 2010. So specifically, since we're at an Exposome conference, NIH's research priorities related to the environmental sciences is that we're really trying to investigate how environmental exposures throughout the life course shape health outcomes of older adults. And so this then requires us to, as Dr. Watanabe mentioned, taking a more holistic view of exposures, so both in terms of the timing, the duration, and intensity of these different exposures. So we're very interested in not only the physical environment, but also the chemical, the social, the psychological, geographic, economic, all of that combined. So I think really the exposomic framework is a very nice model, but as Rick would mention, I think later on in this workshop, what exactly is the exposome and how do we define it? And I think that we're really looking to you, the audience in this room, to help us with that process. And NIA recognizes that exposome really affects risk and resilience through these age-related diseases and conditions. And so how can we use Alzheimer's disease as a model and using the exposomic frameworks to try to advance this? I really like this slide. I saw this at a traffic-related air pollution workshop earlier this year. But this framework is a really nice model to look at ultrafine air pollutions and traffic-related air pollutants. I know Joel will be very excited about this. To talk about how initial exposures and risk factors, on this left, kind of contribute to initial molecular and cellular effects in the target tissue, and then ultimately how that leads to early, pathophysiological responses, to early detectable but subclinical effects, and then ultimately to the disease state of interest. So ideally, a research program would be able to kind of consistently document the effects all the way along this route. So being able to demonstrate this cascade from exposure to a disease outcome. But also you need to kind of consider the genetic and biological risk factors that may contribute to the risk of disease. And importantly, I think this framework also shows how two main places where the interplay between environmental factors and social factors can result in health disparities. So first, the key difference exists between social groups and exposures, so the different health disparities. And then secondly, also in how the social environment may impact resilience and the outcome of these individuals, and how the built environment and other educational opportunities can influence this occurrence of this exposure-related disease risk and resilience factors. So we know that there are a lot of interactions between aging, genetics, and the environment in the pathogenesis of Alzheimer's disease. And we haven't elucidated all the pathways that could potentially lead to Alzheimer's disease and related dementias. So, we estimate that the environmental components account for roughly about 35% of the AD risk factors. And so, but what else is there? What is the interaction between the aging, oxidative stress, epigenetic alterations, and the genetic markers like A beta, ApoE4, inflammation genes, and how that interacts? And so, all along from MCI or mild cognitive impairment and dementia, all the way to can we have both diagnostics, but also ultimately to therapeutics? So, can we find a cure for Alzheimer's? I think ultimately that's the goal for NIA. And so really really need to assess the exposome across the entire lifespan. Not just looking at the older populations, because we know that the windows for etiologic environmental exposure start much earlier on in the life course. So what is this? Can we measure these exposures? What is the internal dose? The health outcomes? I know Gary will be really excited, but we're really interested in seeing if we can find these markers. What is it? Where along the life stage for these etiologic exposures, within clinical and histopathological changes that begin early in life, that then ultimately lead to cognitive decline that's clinically apparent, and then finally to an Alzheimer's clinical diagnosis where the function and memory drop off significantly. So are there prodromal markers, so markers before you get to the diagnosis, somewhere in here that initiates? What exactly is it within this life course stage that happens, and can we measure it? And so we are very interested in the exposome. So these general external measures like climate factors, social capital, specific external measures like dietary factors, physical activity, and then internal factors, your genetics, your metabolism, your microbiome, how does that impact? We're very interested in dental health and other measures like that, and how that impacts an AD outcome all along the spectrum. So not just an AD diagnosis, but anywhere along the cognitive impairment and beyond. So the goal really is to try to calculate an accurate determination of risk based on individual exposures and characteristics across the entire life course. So this is a nice graphic here from the Lancet 2020 report, where it looks at the population attributable fraction of potentially modifiable risk factors for dementia. And so you can see that having early in life lower education, hearing loss, traumatic brain injury, hypertension, alcohol use, and then later in life smoking, depression, socialization, all contribute a portion of it to potentially 40% might be potentially modifiable, but 60% of it risk is unknown, and that we don't know what it is or what combination of these things at what life stage starts the cognitive impairment, starts the decline towards the individuals. So for this really terrible disease. So ultimately, we want to try to adopt this precision medicine approach for treatment and prevention. So ultimately, it could be multiple etiologies, multiple prodromal phenotypes, multiple progression trajectories. And so can we find the right target for the right patient at the right drug and intervention level for the right dose at the right stage of disease? So within this very mixed patient population, traditionally, you have one treatment, and the standard treatment is just, will that apply? Will that be helpful for each individual? Versus a precision medicine approach where it's more tailored, that you have multiple treatments that are targeted for the right individual at the right stage at the right time. And so I think the exposomic ecosystem is really poised right now. This is really more than just a data science, computer science challenge. But I think that the data science ecosystem is really poised with novel tools and methods to try to advance the science. So combining satellite data with environmental exposure data, neighborhood GIS data. I know Itai and Mike would be very excited to hear this. But also with mobile and digital data, and combining it with electronic health records. NIA has invested a lot in trying to put a lot of this information into a repository called the AD Knowledge Portal, to try to make it easily accessible for the community to access the data. And then also working with our partners at NIEHS with the HERE program, and also the Common Fund, the Bridge to AI, and using a very fair data model, which represents data that is findable, accessible, interoperable, and reusable. So really trying to make data easily accessible across all the different disciplines. Can we make these advances? And so the AD Knowledge Portal is really an infrastructure for sharing diverse data types. We require our participants to deposit not only human and mouse and model system data, but also the transcriptomics, the epigenetics, and metabolomics, imaging data, and then also a lot of processing data. All that is stored on the AD Knowledge Portal and freely accessible for investigators around the world. And so with these advances in exposomics, and especially with artificial intelligence, a lot of these high throughput technologies can be leveraged to take advantage of these next generation techniques. Using sequencing, mass spec, genotyping arrays, and bioinformatics to really integrate these multiple omics. And then combining it with targeted and untargeted analyses using like the systems from the NIEHS HERE program, can we and then combining with sensors and personal dosimetry data, can we use AI or other advanced methodological systems to make some improved discoveries? And so this is all mentioned in a variety of workshops that we've held, looking at precision medicine and AI and the exposome, specifically to AD and the brain. A lot of data is available at a multimodal biobank scale, so can we combine the genome, the phenome, the exposome data from these large biobanks like the All of Us program, the UK Biobank, Medicare, and SEER data. And then leveraging these resources with AI, can we address these questions of interest? And so the N3C was really a great example of how, if you have reduce all of the barriers to access, and including all that information, clinical data, EHR data, all in one place, we made a lot of rapid advancements on COVID in a very short period of time. So can we use that model from the N3C, to look at other health outcomes like AD? So can we use the AD Knowledge Portal and then combining with smart city data, from satellite sensing data, from the Internet of Things? Can we use that to make some discoveries looking at AD, looking at Alzheimer's disease? So there are a lot of limitations, as you know, in the current exposomic data analyses. The scalability. A lot of conventional approaches struggle with large-scale data sets and how to incorporate them at the right scale, at the right time, at the individual level. The variety and complexity of the data are very diverse. Diverse structures and unstructured data. How to make sense of all that and how to interpret that data, and also a lot of sparse and missing data. The coverage of the exposure metrics varies over time and space, and so especially when you are looking at an etiology of disease that spans decades, a lot of the satellite sensing data aren't great prior to 2000, right? You're dealing with very rough estimates, and so can we leverage these next generation of cohort studies, especially children's cohort studies, birth cohorts that have started since 2000, have better data at birth, at conception, and moving forward to look at some of these health outcomes, not only in the babies, but also in the mothers and the parents as well, who are then, when they enrolled, were in their 20s and 30s, and now they're in their 40s and 50s, and at a stage where you could actually measure cognitive impairment down the line. So a lot of themes are that the available data are often underutilized in biomedical data, so really looking for investigators such as yourself to think creatively at the data that are available, and taking these new methods and algorithms and applying them to your countries, because we are very interested in the diversity around the world, not just in the United States. So very much interested in low and middle income countries, the experiences in Indonesia, in Malaysia, in Japan, in China, in Nepal. We're very interested in that. And then a lot of challenges in trying to harmonize and integrate this data to build predictive models at the individual level. And so can we characterize and mitigate these different inequities in health and healthcare? So taking some advantage of some of the structural advantages of some countries with universal healthcare, like in Korea, like in Japan, in Taiwan, can we leverage that to help inform disease progression? So this is over the past 10 years, NIH has significantly expanded its investments in Alzheimer's disease research. So through a sustained effort and strides in trying to understand Alzheimer's disease, we grew at the National Institute of Aging, grew from a modest-sized institute with about $1.1 billion US in funding per year in 2014 to most recently $4.5 billion in US in our budget for this fiscal year. But you can see from the blue bar that much of it is devoted specifically to Alzheimer's disease-related funds. So and Alzheimer's disease outcome or anything along the trajectory from mild cognitive impairment all the way on to a disease diagnosis. And then also with aging as well, so a general aging fund specifically for Alzheimer's. So these are our pay lines for CSR review grants. So I told Dave I had to put this on there, so just to encourage people to apply to NIA. That all applications, so we have two pay lines actually. A general pay line, which is for the general aging, and then for Alzheimer's disease specifically. So for pay line below $5 million per year in direct costs, so pay line is 17%, and then above $5 million a year. And that actually does happen. We actually do fund a lot of studies above $5 million a year at 14. But we also have NI, so which means new investigator R01s. And so those are for investigators that have never received their R01 award. And ESI is early stage investigator, so within 10 years of your PhD. So these are the pay lines currently at NIA for fiscal year 24. So this is for this year's funding. So I encourage a lot of the students who are here around the world to apply to NIA. Then also we have pay lines specifically for NIA Notice of Opportunities. So again, we have a general pay line and then an AD pay line. And so you can see for career development awards like K awards and R00s and then fellowship awards for you to complete your dissertations and your academic work that is quite generous, quite high. So encourage you to look at NIA. And so I just wanted to kind of review some of the NIA investments that we have in the past several years. So there's been a lot of efforts that we funded and RFAs specifically around the exposome, not only in understanding cohort studies and toxicology, but also in gene-environment interactions, and looking at toxicology and model systems, looking at administrative supplements, and then also in trying to have a coordinating center looking around the social determinants of health. And so the next slide actually is from the administrative supplements, and I think several of the investigators who received these supplements are here at this conference, so I encourage you to look them up. I know Amy is here, sitting here, and then Gary is here as well, and I think Rhoda is here as well. So talk to them about their experiences and supplementing their studies, on specifically looking at AD. But also it's like, just because you miss those opportunities doesn't mean that there aren't more. And so I was like, wait, there's more. So we have ongoing funding opportunities. So this is a NOCI that we have, specifically looking at opportunities related to epidemiology and Alzheimer's disease related dementias and cognitive resilience. And so we are very interested in, in expanding and augmenting existing longitudinal studies. So your birth cohorts apply. Enabling precision medicine through deep phenotyping, so looking at other outcomes, looking at prodromal markers like loss of smell, looking at oral health, looking at multi-ethnic cohort studies, so very interested in diversity. Most of the Alzheimer's disease studies have been on Caucasian populations, so very interested in Asian, African, South American populations as well, and especially in low and middle income countries. And also exploring the trends and risk of AD and risk factors and protective factors as well. So the exposome is not all one direction, right? So what are folks doing that may reduce the chance, reduce the risk for developing Alzheimer's disease? We're very interested in that as well. And then really trying to harmonize complex data sets. So get out your smartphones, scan that QR code, and it'll take you to the funding announcement. Or just look up the NOTAG 21-045. But some of you may wonder, like, I'm coming in from the exposure side. What measures do I collect? Like, how do I collect an outcome measures? And so this is the Harmonized Cognitive Assessment Protocol that we use as part of the HCUP network. It's an international research collaboration to measure and understand dementia risk around the world in these longitudinal studies. And it really is meant to harmonize methods and content to facilitate cross-national comparisons. And so the HCUP network is just one of many networks that NIA has funded over the years. And this one is using the Health and Retirement Study in the United States from the University of Michigan. But then also Chile, China, England. This is in Africa. The Halsey, La Ciudad is in India. And then also the MexCog is in Mexico. So we fund a lot of different studies and try to harmonize and make sure that we're collecting the measures in a unified fashion so that it would be easier to compare results and try to compare apples to apples. And so in the end, Japan has a lot of advantages to contribute to Alzheimer's disease in science. So there's a lot of environmentally well-characterized cohorts, including birth cohorts like SOGIs and JECs. And so collecting measures on the air pollution, occupational exposures, endocrine disruptors, and phthalates, and PFAS and PFOA, and the diet. What is it that is occurring that Japan has such a low prevalence of Alzheimer's disease compared to European populations? Is it universal healthcare? Having access to these longitudinal EHR data is actually extremely valuable. But could it be something behavioral? Could it be something within social determinants? What is it about the blue zone in Okinawa that you have a much larger percentage of centenarians, those who live above 100 years old? Is it their lifestyle? Is it their diet? What it is about healthy aging, I think that we can learn from and try to emulate across the world. And really trying to encourage international collaborations. And we're very much interested in it. We know that we won't be able to find the answers if we just look only in the United States. So what is it from these other populations, from the Asian populations, from the African populations, from the Middle Eastern, and from South American and others around the world that can help inform us to look at this disease?